Okay, we're going to get started. We have an amazingly full agenda today, so I'm going to try to run the train very efficiently. We'll just start with introductions, and we'll just do the assembly members on the committee, or assembly members or the committee present. The rest of you all know who you are anyway. Sorry, you was training?
Dick Training, just something.
Pete Peterson, Assembly.
Bernie Hall.
Bill Evans.
LB3 Jackson.
And Ms. Dombowski is here in the building and should be joining us any minute. Like I said, we have a full agenda. One of the things I want to do, it's not on our agenda, but we have Mr. Hall here with us who wants to address some issues as a follow-up to the alcohol tax issue that somebody dealt with on Tuesday. Mr. Hall, it's yours.
Thank you. And I am going to be brief because I know you have a full agenda, and I appreciate you giving me this privilege to come in. And what I want to share is, I don't have a lot to go over. We've got some information to share. It's a handout. I'm not going to go through it. But what I became very much aware of during the 2 weeks that Ira and I were buried up to our eyeballs in this and communicating with so many people across the community that's dealing with the inebriate problem is how serious it is and how complicated it is and how expensive it can be. So what I really encourage the committee to do, and I know we had diverse opinions during the meeting, and I respect the decision of the body, but I think the thing that I really want everybody to understand is whether we do this for compassion reasons or we do it as tough love, what I really want all of us to understand is we're dealing with some individuals that have some real significant problems. But the thing that I recognize this as is even greater than that is this is an issue that we have as a community. And we need to do this for our own image, for our own public safety, and for the fact that it's going to be good for business. We do not present a great image when we go into our tourist season, and people honestly can't go up and down our main corridor of town or go into our parks and play and enjoy those venues because of the fact that it's not comfortable being there with what we're dealing with the inebriate problem that we've got in this town. So the main thing that we've got to do, honestly, is we've got to quit talking about it. We've got to have a plan, and we have to implement that plan. How we do it, I don't know. I do know that we had concerns about doing an end run on the charter. There is a provision in the charter that allowed for what we attempted to do. And we also talk about breaking the budget, but also we need to be very well aware that we've just approved $93 million of bonds to go on the ballot that this community is going to vote on, that if it passes, it's all above the budget cap. Every time we do that type of funding, it's above the cap. And whatever we do and however we address this, we are going to have to address the problem that we need the facilities to be able to house and treat this problem in our community. And with that, I'm not going to take up any more of your time, but I really appreciated the ability to come here and be able to say, I see this as our problem, as an image for our community and our own feeling of self-worth about what we do with it. Thank you, Mr. Evans.
Thank you, Mr. Hall. Are any questions or comments from Mr. Hall on that? I think you won't find many people disagreeing with you on anything you said.
I never felt that at any point in this. I don't think there's not a soul that's not concerned about this. We just got to figure out a team effort about how we address it. And with that, I'm going to go check on my...
Yeah, I realize you have to go check on your wife, and good on you for that, but please feel free to join us, because we will be doing what we can in this committee to do exactly what you said and try to find that plan.
Thank you.
Thank you. With that, thank you, Mr. Hall. Our first presentation today is from Choices in Rural Cap on the recent grant from the state, and they're going to give us some info on that. So, is Corinne's there? Oh, super.
Yeah, so it's me and Corinne.
Okay. Take it away.
Thank you. So, good afternoon. My name is Akila Osakwe. I'm the new Executive Director of Choices, and this is a presentation on the ACT program and the Housing First. So just to give you a little bit of a background about Choices, we are a recovery and peer-oriented organization. We have extensive experience with the serious mentally ill, chronic inebriate community. We have a peer bridger program, which is about bridging people who are individuals who are institutionalized but on their way out into the community and getting them hooked up with resources. So we have peer bridgers, about 5. Soteria House, we're a recovery-focused short-term assisted living facility, and that originally started with individuals who were first rate, but but it's recovery-oriented. And it's different from assisted living in that it is short-term. We have recovery coordination, which is essentially case management, which is individuals who are help with individuals who are experiencing serious mental illness. And it's a good service to get them hooked up into Social Security, disability, and Medicaid. Then our newest program is the chronic inebriate program, anti-recidivism treatment, and that we're really, really excited about, and we'll learn more about that as this presentation goes on. So with that new program, the target population will serve 100 of Anchorage's chronically homeless individuals and the complex needs. So individuals who have low functioning, who have substance abuse disorders, and what we expect is 75% to have substance abuse, so co-occurring with mental health and serious mental illness, and to have a history of trauma. The other factor is that 52% of the single homeless individuals in Anchorage are of Alaska Native and American Indian percent, even though they comprise of 7% of the population. So the target population are people who are chronically homeless, and because the current system, let me just turn this, sorry, a little bit towards me. The current system that we have in place now requires abstinence and compliance before offering housing, and this program basically creates no barriers. If you're homeless and you're chronically homeless, then you will be served by the ACT team in Housing First. This treatment approach has, the requirement, the preconditions has not been effective with the chronically homeless group. What we're learning is that if someone is not stabilized, then they're not going to be able to receive services, and it's just a no-brainer. If someone's in a community and chronically homeless, they're not going to want to receive services, or they're not going to. It's going to be very difficult to engage in these services until that big piece of housing is taken care of. So individuals with co-occurring mental illness and substance abuse, so serious mental illness and substance abuse, are caught in this vicious cycle of homelessness, incarceration, and heavy reliance on emergency services, which is very expensive. So this is just to give you an example. And this is, a very, very common pattern, and this is through rural Alaska, Anchorage, just the state of Alaska. If someone does not have that stable housing and they're on the street, then they're just inevitably going to go through this cycle of shelters, jail, emergency rooms, hospital, and they just go. So the Housing First program, and that was created by Sam Sembrus, he's based on the East Coast, it provides housing first, so back to that no barriers or preconditions. And then after the person is stabilized in housing, then you can introduce the services. So the housing is the very first intervention, if you will. The housing is provided in apartments. It's a scattered site model, so meaning that it's all about if an individual wants to live in a particular neighborhood, we will place them in that particular neighborhood. And the idea is that we want them to be stabilized, so if you place them against where they really want to live, then we're looking at this cycle again. So we really want to work with them to place them where they feel comfortable. It fosters a sense of home, and it really does help integrate clients into the community. The Housing First model is evidence-based, so it may seem impractical because you're placing people in various neighborhoods according to their choice, but it's evidence-based and it's been replicated across, more than 40 cities in the United States and now internationally. So again, the Housing First model is from homelessness to permanent housing. So you just want to move someone from homelessness to permanent housing so that they can receive services that are ongoing, flexible, and with home visits, and we'll get more into that. So after housing, then the focus on health and wellness occurs. So these are when the wraparound services occur. So health, wellness, dealing with chronic and acute health problems, getting someone actually to a place where they can consider taking on a job. So getting them stable to the point where they're considering employment, dealing with their alcohol and drug abuse and mental health issues, and then ultimately, connecting with family members. And that is the idea, is stability, and that, with wraparound services. So the not wanting to just place someone in housing without services, but place someone in housing with wraparound services that, as we proceed, you'll see that, just consistent many points of contact so that individual has the most leverage to sustain housing. So under Housing First, we have assertive community treatment, which has existed for about 40 years, and that's another evidence-based model for treating people with serious mental illness and substance abuse. And that is with a multidisciplinary team of medical, peer, behavioral health professionals. And this team it's an assertive team, and it's, that word is utilized for a reason, because again, it's not, okay, we're going to find this person housing and then we'll leave and then they're left in housing. It's that they have a wraparound team that is very much a part of their lives and, on a 24/7 basis. So they get, a lot of support. So the ACT team members, we have a clinical team leader, a psychiatric practitioner, the mental health clinicians, registered nurses, then we have our specialists, the substance abuse, peer, and housing and employment. And the idea is to keep the ratio caseload to provider, team member low, so that, again, they're well served and they receive the most wraparound care. And in bold, you see at the bottom, make frequent home visits. So again, many points of contact, very well supported, and the idea is that they're sustaining, they're sustained towards wellness and recovery, and that they're able to keep their housing.
Excuse me a second. We got a question from Ms. Gray Jackson.
Actually, thank you. It's not a question. I just wanted the public to know that I'm not sitting here blatantly texting. We have 3 people trying to get onto the speakerphone, so that's what this is all about. I just need to say that. Thank
They're
you.
trying to get on here?
Yeah, and he's texting me back and forth. That's not your issue. No, it's ours, but I just want folks to know that I'm not sitting here blatantly texting while she's giving a presentation. So I needed to say that, but thank you.
And I do
Mr.
have Sam Sebris here as he's actually should be online, and he's going to speak to some of the slides.
Is he there? Because there are 2 others trying to get
Yeah,
online and
I don't
they
know.
can't.
Is Amanda here so that we can at least?
They're working on resetting it because besides your person, there are 2 others
Two others,
sitting there
right.
that are trying to get on, and
Okay.
they can't. Yeah. So, but Amanda's resetting the bridge.
Okay, so I may just dial him in on my phone and hopefully. Okay, so the ACT team, the assertive community treatment team, and the intensive case management team will be coordinating. So here's my counterpart, Corinne, and we will actively outreach to identify the chronically homeless who meet criteria for serious mental illness and co-occurring substance abuse. So again, providing that housing first as the first crucial intervention so that they can be stable. And again, when an individual is stabilized, it reduces recidivism, and that's the idea. When they're stabilized with wraparound services, evidence-based, and so. So the treatment services we provide, the ACT team provides, is assertive outreach and engagement. We help clients with goal setting and assessment of their needs, service needs, medical services. So the psychiatrist provides med management.
Assemblymember Honeman?
Yes.
Okay.
Okay.
Med management and monitoring.
There's a gentleman from Choices program on as well.
Right, the Pathways Housing Sam Samberis.
Oh, good. Hi, Sam, it's Akila. We're a little bit into the presentation, but we will, there is a slide I would like you to speak to. So the medical services, again, medication management, so they have, again, these are individuals who have serious mental illness, so medication management is a part of that, and assessment and monitoring. The physical wellness monitoring by the RNs, behavioral health services, crisis intervention. So if a client is in crisis, they will receive care 24/7. So it's a 24/7 team, and mental health assessment and counseling. Specialist services, peer support, employment, substance abuse. Just to take care of. Definitely the substance abuse piece, money management, housing, so there are a myriad of services that these specialists provide. Again, ACT team members will meet with consumers at least once per week in their homes. That's a minimum, but the idea is there are multiple points of contact throughout the week so that they're very well supported. So Sam, there is a slide that you included, the housing first versus treatment first, percent of time housed, and that's a Canadian study that, if you wouldn't mind speaking to.
Well, I took that study and it's representative of the studies around homeless first, housing first in general. This one was particularly compelling because it was a very large study. It involved 2,252 people across 5 Canadian cities, some of them intensely urban, others suburban and rural, from Vancouver to Moncton. And because the sample is so large, we can have greater confidence in the outcomes. And people across these 5 cities were identified much in the way that Akila has described: long-time homeless, mental health problems, addiction problems co-occurring, and about 80% also had physical health problems. They had been homeless on average on and on for about 5 years, and people were offered, the usual kind of a stowaway program. We call that program where you go to shelter, and then eventually, hopefully, you get stable and prepared for housing. A lot of homeless programs do this treatment first, preparing people for housing on the assumption that they need to be made ready. And the others went right into housing and received the kinds of supports that were just described. And that graph shows you just a 12-month outcome of how much more efficient the housing first approach is. People go into housing. Well, that's easy to do because people are very interested in signing up for an apartment and meeting the terms and obligations of a standard lease. But the real effectiveness of the program is that not only do people go into housing, but they actually stay stably housed over time because of the supports they're getting. And that's what that graph shows.
Thank you.
What it doesn't show, the parts of the finding, if I just may add this piece, that there was $10 saved for every $3 invested in this program. There was a cost saving to it, and in that Canadian study, for every $3 invested in setting up one of these housing first programs, the $10 saved were in the form of savings from the reduced use of hospitalization and other acute care services, expensive services.
Thank you, Sam.
Akila, on that, I just had a question. Given the model of having, trying to give people the option of choosing where in town to live, It seems like that's a bit more expensive than sort of the Carlick Manor kind of group homes. Do you have a cost per individual of what this model basically costs?
We don't have a cost per individual, but we are looking for affordable housing options where they choose to live. So if they choose to live in Rabbit Creek, that's not going to be happening. I mean, it really has to be in a neighborhood that, there is that affordable housing option. Does that answer? And
Yeah, well, the vouchers are like HUD vouchers.
Right.
They only pay for what's called fair market value, which is really the lower end of the market in terms of affordability. So it's not choice like in an absolute way, it's
Right.
choice within the reasonable rent
Yeah.
market of it.
right.
Mr. Traney has a question.
Thank you, Mr. Chairman. How many people are you going to talk about putting into home? Are you talking about one individual buying a house for that one individual? Or are we talking about multiple people going into a housing first or what?
So we have the goal of housing 100 consumers and independent housing for each consumer. So if someone is really low functioning, so if they have a mental illness or a substance abuse disorder where that precludes independent living, then assisted living would be, obviously the feasible option. But the idea is that they're living independently within their own homes, so their own apartments.
Any idea what the cost is going to be to do this?
Again, it's back to the affordability HUD vouchers within that range. It falls in the low range.
I can, if I may, say a comment about the cost of the program per person per day. We've looked at that. And this program, in terms of both if you add up the rent and the support services people get, it comes to, depending on the, salaries and the rent that you're paying in the community, but it's generally less than the cost of a shelter cost where you have to have, say, a 724 or a safe haven or any of these transitional housing programs where you have supervised staff on site and people are living in a group home. That would be, let's say, $75, $85 per person a day. This program is closer to about $35 to $40 a day on the rent plus services piece. Much cheaper than a day in the hospital, $1,500 a day, jail cells, $600 a day, and so on. So on a strict comparison of where homeless people end up, it's actually on the very lowest end of per person per day cost.
Is it Sam? Was that?
Yes, Sam Severs.
Sam, are those numbers, is that Anchorage or is that other studies elsewhere, those numbers?
Those are just average numbers nationally.
Okay.
I can say this on a project-based level for Rural Cap, it's about $40 a day per person for the operations and supportive services, with people paying around 30% of their rent. So in a project base for us, the average person pays $250.
Thank you. Please continue.
Okay, thank you. Okay, so regarding our stakeholders group, Choices will be partnering with the division to form the stakeholders group. And we're looking at the following, organizations or areas, without being explicit of who, because we haven't formed it yet, but we're looking at the correctional system, court system, emergency response agencies, and shelter systems as part of that group. And we plan to form that by March 31st, but we're partnering in that. That is a referral group which will help prioritize individuals. So they will be guiding the ACT team as far as who to look at, who needs services immediately, and they'll be instrumental in helping us identify the individuals who need the most support.
Again, it may be, since it was a sort of a local business community group that sort of generated this grant, it may be useful to reach out and have them as a stakeholder as well, especially obviously Fairview, which is heavily impacted by this and has a lot of firsthand knowledge of where you might turn for some of the people that you need to reach out to.
Okay.
Mr. Steele?
Yeah, just one quick question. Just a rule of thumb in terms of success rate of treatment first versus housing first. What are the success rates
For treatment first versus,
versus housing first?
you know, I don't have that numbers for that, but what we do have is the recidivism into jails, and we know that these individuals were privy to services, and they still cycle through the jail system, the emergency systems, and, you know, that whole cycle. So it hasn't, just from that standpoint, had much of a success, because the homeless piece is still there, and again, there's that stability that is lacking. And so that's why this approach, you know, we're trying an evidence-based approach that we're pretty hopeful and certain will work here.
So I think it also depends on how you define success. So we often define success in Housing First projects as housing retention for a year or more. That generally, for most programs, is easily upwards of 80%. For Rural CAPS programs, that's generally what it is. So if you're talking about housing retention, if you're talking about sobriety, we don't generally measure success based on full sobriety. What we do measure success on in regards to recovery is reduction in symptoms, reduction in frequency, reduction in amount of drinking, and we find that all of those are true in Housing First projects. And all the studies back on Carlick Manor have indicated those are true as well.
I imagine there is some sifting through in terms of whether the individual is ready for anything like that.
Absolutely, yes. So we do assess. So part of the what the team does is assess individuals for, you know, needs, and it's a vulnerability assessment. So there is that.
And potential for success, I suspect, has to be one of those factors.
You mean as far as whether or not they'll be successful in housing?
Whether you provide that housing first model, you've made some assessment as to that this person is a candidate for success in this kind of model.
Generally, that's not how
Yeah,
it's done.
yeah.
I mean, generally, we rank on vulnerability, so we're looking for the most vulnerable people, not will they be successful in housing.
Right.
What we do consider sometimes is functionality. You know what I mean? Can this person do certain functions of daily living that might look at housing choice or housing options? But the goal is to take anybody, regardless of whether,
No barriers.
regardless of need, with minimal barriers.
The ACT team evaluation is going to be, it will be done by University of Anchorage, Alaska, and it's contracted by the division, and we'll focus on program fidelity, just making sure our team is operating according to standard, engagement, and reduction of acute care systems, so we're looking at that recidivism piece, and reducing homelessness, so in just making sure, you know, back to recidivism, measuring whether or not this individual is improving. So improving, you know, in their substance abuse, their mental health, employment, and their overall wellness. And our implementation timeline, so our program development, we are on schedule, and we are recruiting right now our ACT team, and we expect to be completed by March 31st. And again, as I mentioned, the stakeholders group completed by March 31st as well, and then we begin our outreach on June 30th. And that, with that said, if you have any questions, definitely, I think we have a little time, or we're off time.
Mr. Chairman?
Yes, sir.
Okay, so I just want to make sure I'm hearing this correct. Are you saying that there is funding for 100 clients in the Anchorage area These are folks that you've already identified? Is that what I'm hearing?
No, we begin outreach in June, but so we are 100, that's the program, the 2.5-year grant is to identify 100 consumers, or onboard 100 consumers who are chronically homeless and have complex needs, so that's substance abuse, trauma, but mainly substance abuse. And the idea is to onboard them within that 2.5-year period.
Okay, so I just want to make sure I'm clear. Is it funded for 100 persons, their care team, housing, and I guess you could say the wraparound care? Is that already funded, and if so, by what source?
The housing piece, we are working on the housing piece as far as identification of housing options, but the ACT team is funded. So that our team is funded to provide the wraparound services, and then the housing piece, the division and the trust and Rural Cap are working to identify those housing options.
And that includes the funding?
It includes the funding.
So the service teams are completely funded
Right. The
for
service.
2.5 years.
And how is that funded?
That's through the grant.
Through the grant from the Division of Behavioral Health?
Okay, so state funding?
Yes.
And so is there a price or a cost estimate? And I know that you're talking about variables and such. Is there a cost for the housing piece, or have there been funds identified or a funding source that you'd think are optimal?
So we know that there's identified potentially 7 housing choice vouchers through Alaska Housing Finance Corporation. Both Choices and Rural Cap have not competed for those resources yet, so we'll have to see how that competition works out. But together, total, we need to house 160 people for both of our programs, so obviously that is less than the voucher resources. Rural Cap has a potential option of bringing 50 more housing units to the table, but we're still working on the funding piece as well. So I think we're working diligently on the housing funding piece, and we're hopeful.
Okay. Thank you.
You're welcome.
Chris, real quick.
Yeah, so the RFP had mentioned there were 100 HUD vouchers that were targeted or identified by AHFC for this, and I'd spoken with Mark Romig at AHFC, and he said those vouchers weren't under threat from the state budget cuts because they were federally funded, so now there's 7?
I think that the 100 is the statewide allocation, 70 is the Anchorage
Oh,
allocation.
70, okay, not 7.
Seven.
Yeah,
We all heard the seven.
I'm sorry, 70. So if we talk about 50 plus 70, we're getting close, but we're not quite there.
No.
Yeah.
Yeah, but, okay.
So maybe I can do mine, and then we could take joint questions.
Yes.
Okay, so Rural Cap also applied for the same request for funding proposal that Choices did. There were 2 parts of the grant proposal. They applied for one, and we applied for the other, and we received the other set. The request for funding proposal was the State of Alaska Chronic Inebriate Anti-Recidivism Treatment Program. So we applied for the section called ICM, or the Intensive Case Management Team Program. So our goal, when we received a grant agreement on January 1st, so that's obviously not too long ago, and our goal is to take the 6 top utilizers of the Anchorage Safety Center through a housing first approach with an intensive case management team, and to serve the most vulnerable people with the most complex needs, with the longest length of homelessness, regardless of their housing barriers or challenges. So we responded to the RFP in November. We received notice of the grant agreement. We're going to receive $1.875 million for 2.5 years. And the RFP really described clear service standards and practices, just to make it clear that the funding was for services, not for the housing piece. So grantees had to bring their own sort of housing piece to the table for that. So the funding is for the services, but within a housing first approach. It also requires a third-party evaluation, which we'll talk about later. So our timeline is very similar to Choice's timeline, January through March. We've already started our initial hiring. We've hired our program manager. We've hired our compliance position. But hiring takes a long time when you're starting a new program. There's not a great job pool. We often have to put positions like this out multiple times. And it's hard for nonprofits to recruit, particularly when you're competing against things like hospitals, state psychiatric centers that can pay a little bit more and have a more robust benefit package than nonprofits. So we are then, from April to June, we'll continue to work on hiring. Hopefully we'll have a good applicant pool when people get out of school in the spring. Training and steering committee development, and we're looking at June or July implementation as well to put sort of the boots on the ground. And then we'll have the service teams in operation through, right now we have the funding through 2016 and 17. So what is an ICM team and how does it differ from an ACT team? In Housing First, there are definitely two service models, and I want to make it clear that the ICM team is not a new model for Rural Cap. We actually just finished a 3-year SAMHSA grant with an ICM team. This is the model that we use throughout our division, although the ACT team is new to Alaska, different service model. So within there, you have an active treatment team. The treatment team is community-based. We go into people's homes. It's not come to my office, fill out this paperwork. It's a boots-on-the-ground team. We expect that the services will be intensive and in long duration. For example, at Crowley Manor, the service team will work with people many throughout their entire pretty much life with us or in the program. We are focused on, again, most people are co-occurring serious mental illness with severe addiction disorders. Our caseloads are a little larger than the ACT team, about 1 to 15. And ICM teams have an outreach component and may have a peer support component. And so this is things that are maybe different from the ACT team. You'll see they have nurses and psychiatrists on their team. We have to actually go out and broker those services. The other difference is ACT teams have specialties like employment, substance abuse, and housing. So all of those case managers work with everybody on the team, all 100 people. ICM teams, it's like you're the primary person for your caseload. So you are the employment, the substance abuse, everything to those 15 people. So there's not this sort of specialty practice. So I think that Keila went through Housing First, and so I'm not going to go through that as much. So this is our team. We have one clinician, one basic therapist, 4 ICM case managers, 1 outreach specialist or outreach case manager, 1 program manager who's comparable to their clinical team lead, 1 compliance coordinator because we are going to bill Medicaid. There's also a lot of state requirements on this. There's a lot of paperwork. And we have .1 housing supervisor, which is our tenancy support, somebody that does leasing, landlord relationships, income verification, all of that paperwork. We, although it's not required for ICM teams, the medical piece of it, we have chosen to do a contract nurse case manager with our team because the medical issues with many of these people are quite complex, and we chose to put that on the team. And also we're doing some contract peer support services with the Alaska Mental Health Consumer Web. The rest of the funding is going for direct service, office space, IT, training, administration. So we have a couple phases. Once we get the team fully in place, we'll have sort of an intensive outreach phase where we'll identify all 60 people. Basically, we're looking for the municipality to give us a list of top users. We're going to work from that list first. Then we're then going to use a data-driven tool called a vulnerability assessment tool, where we go through and we find out more information of people on those lists, looking at what is their vulnerability and sort of work our way down. And then we will have coordination with the ACT team to make sure that nobody is duplicating and identifying that we are targeting the same people.
Any question, Mr. Chair?
Go ahead, Paul.
Okay, so I heard 100, and then I also heard referrals from the ASP super users at the sleep-off center. So, was it 6 or 60? I'm sorry.
60.
60.
Yeah, 60. So my target population is the 60 is the top users of the Anchorage Safety Center. Choices, the difference between choices is they could be homeless but top users of other systems. So we have lots of people that are top users of our emergency rooms, our psychiatric systems.
So I want to make sure I heard it right. 60, correct?
60.
And so I heard you say, follow up if I might. I heard you say the money is covering the services, but not the housing.
Correct.
And do you have an estimate of what it might cost to house 60 people, and do you have funding source identified?
Well, that's a complicated question. Generally, it costs us $40 a day to house people. This grant will cover part of that $40, and I have to work it out. So it might cover, half or part of the service team, but not some of the other housing costs.
Okay, thank you.
So I'd have to work on the math a little bit. So RoCap right now, where do we sort of intend to housing first? So we will identify people with outreach, and our goal, their primary treatment goal is number one, housing. Get you in housing, and generally that is not a hard sell for us. It is very rare we offer somebody a housing unit and they turn us down. So rare, never. I don't think I've ever seen it. So we have 228 housing units. So we are going to try to work people into our housing inventory as it exists right now. We have a significant amount of vacancy, we know, in July on our Safe Harbor and Merrill property. Our issue with this property is that we are applying for a variety of state grants to cover the rest of the housing operations. So we hope that we'll be funded there. And we will prioritize our housing waiting list for this team. So we can choose on our applications to rank different applications differently, and people that come in from the Road Home Project, that's what we're calling the intensive case management team, will receive a higher priority for those units. We know we also work people into other existing systems. There are housing vouchers for veterans. If we identify a veteran, we'll work them into those systems. We know that there's some other housing available. We'll try to work people into those systems based on their housing choice and their eligibility. And then we also hope to access some of the state housing vouchers through the Moving Home program. So what does the team provide? Really similar to Choice's team, except for, as I explained, the case management is different. We have to broker some more of the services, particularly the psychiatric services. And some people may, if they're on certain properties like Carlick Manor, could have access to 24/7 safety monitoring assistance, medication observation, and additional services. So just to make this clear, evidence-based practice means it's been studied by a third party, that it has backup to it. So these are all treatment evidence-based practices that are often used in conjunction with Housing First. And these are the practices we use in regards to services. So these are in our applications. So Housing First is an evidence-based practice approved by the federal government and SAMHSA. Intensive case management, also an evidence-based practice on how you put your service team together. Harm reduction is the substance abuse model that we use as an alternative to the abstinence-based model, trying to get people to reduce their use. Motivational interviewing and enhancement therapy. 100% of Rural Cap staff are trained in these treatment practices. It's trying to get people to motivate internally to make changes in their behaviors. And seeking safety and Hazelden integrated dual diagnosis. This is what we use as sort of our group therapy model in all of our programs. So these are useful links. One is the evidence-based practice database for the federal government. One is SAMHSA's homeless database on treatment for people that are homeless. And the other one is some sort of evidence-based practices on the Corporation for Supportive Housing. DBH has contracted outside of us and outside of our grant for the UAA Justice Center to do the evaluation. So we'll be working on the evaluation plan for that, looking at housing retention, emergency service usage, healthcare costs, and recovery. We also are required to do a stakeholder advisory group. We have some prescribed seats based on what the RFP said that we had to have. Some of those are identified. We've also chosen other seats that we would like filled from the faith community, the court system, and we'd like to have some connection between the ACT team and the ICM team, so we're inviting choices also to be on our steering committee. For the seats that are not chosen, we plan to go out in March and put out like a really short information form and response to the Federation of Community Councils, the Anchorage Coalition and Homeless, and other community listservs to try to recruit the steering committee. So that's our presentation. Questions?
Sure, we have a question from Ms. Gray Jackson and then Mr. Steele.
Thank you, Mr. Chairman. I have about 12 questions. No, I just have one for clarification.
Yeah.
Okay. That $4 million state grant, Rural Cap and Choices are the two agencies that were awarded the grants.
That's correct.
And Rural Cap got 1.875, and Choices got 2.125.
Well, we got 1.885, and then we have the ability to apply for more funding.
So there's still some money from that state grant out there?
There
That
is,
doesn't add up to $4 million? I'm just curious.
there,
Administrative costs?
the initial amount that we are actually, so the initial amount it's up to 1.885. Yeah, but our initial award amount is 900,000.
I guess what my question is there any money left for anybody else that applied for the grant? No, it's gone. So the money is gone, is the bottom line. Because I know there are administrative overhead
Yeah,
costs. But, okay, I get it, thank you.
I don't think that I can answer that question.
I
had to apply for the RFP with the money stated in it.
Right, and I was just wanted some clarification. Thank you, Mr. Chairman.
Mr. Steele and Mr. Peterson.
Yeah, I'm glad to see that the two of you are working together in terms of on your board or your citizens group, advisory group, that the two of you are working together. It would seem to me with limited personnel, limited housing, same approach, that you ought to be working together. And so I just hope, and I don't know, are there differences that keep you from that, or is that the case?
No, I mean, I think Akil and I are on the phone, it seems like every couple days
Yes.
to each other right now. We're working with them potentially as a contractor on another project. So I think we intend to use some of like the same trainers or cross-train staff when we have resources available. So there is a difference, definitely a difference in the makeup of the service team.
Right.
And ACT is a new model for the state, so, but I think we have a good working relationship. We often refer people back and forth. It's not unusual for our staff to know each other. I'm pretty sure our outreach component staff will know each other well.
And the idea is that we're always communicating, I mean, not the idea, but that we really want seamless service delivery to the populations the population, the chronic inebriates and SMI, so it'll be important for us to work together.
There may be some strategic reason in terms of state funding or something like that, in terms of the two people are going, or two groups are going after the funding, or three groups, as the case may be. It just seems to me there's so many similarities here, and so few resources that, and the same population, that it would be kind of nice to work together as much as you can.
Yeah, so Rural Cap just got done with an ICM team that we ran for 3 years, and the Santa grant ended, so we didn't have any choice with Anchorage Community Mental Health Services. And I can't say that like partnerships are always easy, but we ran that team what we thought was very successful for 3 years. So it is certainly not impossible for two agencies to collaborate and run a team, and I think we have some lessons learned from that hopefully we'll take forward.
If I can follow up?
Quickly?
In terms of...
Can I chime in here for just a second about the ICM team and the ACT team collaboration, which is one of the, I think, useful things about having two models of a team. I think what we're going to try and do is understand the client's needs, and for those clients that have the higher level of needs, more severe problems, if you will, they probably would be better served by the ACT team because there's lower caseload ratios, and I think by working together we can sift through what is exactly the right dosage of service for each of the people that are being engaged in this project. This is really one project with the high needs and moderate needs kind of level of service.
Having been on the community side, there certainly has been community concern about the housing in their areas, and I know Turnagain, Sand Lake, some of the other ones that have come forward and said, oh no, not in my neighborhood, in terms, but I don't think they know that these are small necessarily and that they're in their neighborhood now, but that's a concern by the community too in terms of trying to find the housing.
And I think, that we understand that concern, but the fact that individuals who are placed in those communities have such a well-rounded team to sustain them, and that there has been evidence shown, past a track record of success with this type of approach. I think that it's just allowing us to show that this does work. So keeping open in that sense. So, but yeah, the concern is definitely noted. But with this team, I see a huge difference.
And I think the community also needs increasing and consistent education around fair housing, that the people that we are serving have mental health issues, that is a disabling condition, and by right, they have a right to housing in our community.
Thank you, Mr. Chairman. You had mentioned you're seeking additional housing for 60 people. You have 228 existing units. Mentioned Safe Harbor and Carlick Manor. What about Muldoon and Safe Harbor? Is that where you're going to be putting the additional 60 units?
No. So we are desperately trying to save that for homeless families in our community. We know that there is a need for that, and we are actively seeking funding to keep that as family housing. It has two options. It'll either be family housing, or if we cannot support the services through the funding, we will just change it to regular affordable housing, not special needs housing.
Okay. All right, thank you.
I know there's some audience questions. We're going to have to hold off to the end.
Just got one quick question, if you don't mind, sir.
What's that?
One quick question.
Sure. All right.
Ms. Gray Jackson brought up administrative cost. How much of this $4 million was eaten up by administrative cost? Do you have any idea?
So for us, we have a federally negotiated indirect rate for our agency, and that's 11%.
With the amount you received?
Yes.
How about yours?
And our indirect rate, do you have that off the top? I believe that, yeah. That is a small percentage, but I can get back to you as well with
You can
that.
do
I don't
that,
have that,
appreciate it.
absolutely.
Because I appreciate Ms. Gray Jackson's question, but we just need to get that answered. Thank you.
We'll have to move on. We're running behind here. Our next presentation is from Chief Dennis of Fire Department, talking about their public inebriate initiatives. Chief? Chief Dennis, wrong Dennis, that's right.
And that's really Chief Dennis right there. That's just Wheeler.
I'm a surprise guest.
I think he's going to speak.
All yours.
Attorney.
Thank you, Mr. Chairman. My understanding is the concept that we're talking about today is one that may have originated both through fire department research as well as a concept brought to us through the Fairview community. And the overarching issue, as you know, is that police department, fire department, CSP, ambulance, EMT, spend a significant amount of time dealing with issues related to a small segment of the community that are so incapacitated through drugs and alcohol that they need to be picked up, moved to a safe location, again picked up, moved to a safe location. We do this over and over and over again at great expense. One concept is, are there some ways to limit their access to alcohol? If they don't comply with those limits, are there ways to then to deal with that group? And if we think if we could maybe in some way limit their access to alcohol, that may in turn limit our need to pick them up repeatedly over and over and over. However, this is as far as we're able to describe the concept to you today, because we are not ready to deal with all the intricacies that go with it in terms of Alaska's special constitutional right to privacy explicitly spelled out. Due process, if you decide that this particular person is no longer able to have access to alcohol, how can they challenge that? They have a right to do so. How do you track the data? How many strikes against them? How do we have examples from other places where this sort of work is effective? So we have a general sense of the concept. We have fire department, health department, fire department working on the concept, police department as well. That has not solidified anywhere near yet to where we can actually discuss this in any detail or even really make a presentation to the mayor to say, Mr. Mayor, here are all the different issues involved. Is it workable? Is it not workable? At what cost?
Mr. Trainee, a question whether if we go to where we tell people they can't buy alcohol, are we required them to provide them indigent defense so they get an attorney to argue their case they can in fact use alcohol? Are we going to be required by the court system to give them that safeguard?
That begs the question about their due process rights. It's not a criminal charge, so they may not be entitled to the right counsel, but they
Did you
certainly
look at that issue, though?
certainly would be entitled to some sort of administrative hearing process.
If you look at that issue.
Absolutely.
I want to see
That's-
the
that's on our
impact of
list.
that. Yeah, thank you, sir.
Is there more?
That's where we are today.
Ms. Gray Jackson and then Mr. Bass.
Thank you, Mr. Chairman. The agenda says that we're going to get a presentation from Battalion Chief Dennis on the Public Inebriate Initiative. Is that not going to happen?
This is what we have for you today. There is no
So you're not going to
presentation
give
down
us a
the
presentation?
I don't think I have a presentation for you.
Oh, okay. Well, that's special. Thank you. Thank you,
There,
Mr.
Mr.
Chairman.
Howard.
Mr. Bass.
I just wanted to validate that the Department of Law was putting a kibosh on the presentation.
I'm sorry.
I said I just wanted to validate that the Department of Law is putting a kibosh on the presentation.
Exactly what happened.
What we have for you is not ready for prime time. We're not ready yet.
Okay.
There are a number of legal hurdles that have not yet been resolved.
That's a very clear answer, and I appreciate it. Thank you.
That does free up some time for us. I guess we'll just wait.
So
Do you have a time
Schedule.
table about when you think you may be ready for prime time?
I don't have a timetable, but my sense is within the next couple of months, we ought to be done with our internal review and brief the mayor.
I'd like to say that after 20 years working with the municipality of Anchorage and the fire department, I'm a decision maker. That's what I do. I go to work and I make decisions every single day, from the time I get to work to the time I go home. And
This is something that's been getting worked on for over a year now, in cooperation with the police department, with Department of Health and Human Services, in collaboration with the fire department, and at this point, I guess it's just not been yet for the public.
Thank you.
My apologies.
It's, we understand, and, we understand the legal necessities and being careful. We appreciate the fact that you and the police department are working on this. We understand you're in the front line of this problem. We want you to be successful in this, and we look forward to the presentation when you guys are ready. Thank you.
I didn't wish I would tell them that, but.
Such a silly. I'll give it to you. I think government should be transparent. You should identify what the hurdles are.
Sometimes.
What the issues are, and then you can.
There was trouble with the attorney had to have the attorney.
I didn't catch the dynamic. I couldn't figure out what the hell was going on, so that's all kinds of.
Well, that's I could tell.
It was good.
Built-in
I
suspenders.
knew it from the get-go, but I was
And hopefully there's good results.
Not even, to me,
That's all I got. That's it.
But I'll give you my presentation. Our next, is that Trevor?
Yes, that's who I am.
Our next presentation is going to be from Trevor Storrs. He's going to be talking about adverse child experience study. And Trevor, it's all yours.
Great. Well, good afternoon, everyone. It's always a pleasure to be here. I don't like sitting behind the desk. I'll be out and moving. And just to let you know, as assembly members, this will be an interactive. I'll be asking you questions, and you get to participate and learn about this. One of the things I really want to preface is this is not a program. I'm not talking about anything specific. It's more about philosophy and understanding. Because these are the individuals we're talking about. And I had the privilege of attending the public presentations or the public comments the past couple of weeks around the whole tax issue and these folks being talked about. I've also had the privilege of attending many town hall meetings throughout the years in my involvement with homelessness and hearing about these folks. And we've heard stories like, it's a choice. They're making bad decisions, that they are infringing upon me, not seen as community members, and so forth. And I want you to always just remember that. We're going to be always coming back, and we're going to always relate this to these individuals and what's going on in our community when we're talking about adverse childhood experiences. And to be able to talk about adverse childhood experiences, we'll be talking about brain development, specifically the study of ACEs. And when I speak of ACEs, it's not the hockey team, and it's definitely not about oil. And then we'll be talking about resiliency and how that relates to all these programs. And to be able to talk about these individuals, what we need to do is go back and understand that these individuals were children. And the importance of that is children are our most valuable resource in this state. A lot of people would say, what's our most valuable resource? Oil. Everybody thinks about oil. That's declining, but the number of kids are actually continually inclining. And whether we're talking about a growth of a community, economic and so forth, it's always the next generation. And if we don't give it the energy that it needs, we're always going to be not only having the conversation around homelessness, but many other social, behavioral, and physical ills that are plaguing our communities. And to be able to do that, we need to start talking about the brain. So, this is where the questions come in. It's a little bit of a quiz. It's okay if you get it wrong. Take a stab at it. But the brain, it is the only organ when you're born that's not fully developed. Did you know that? Now, I don't mean in size. Your heart still grows, kidneys, lungs, they still grow. However, they're fully developed. The brain is not. Different parts of the brain develop at different stages. At age 3, how much of the brain is developed?
50%.
Good guess. Higher.
70.
Higher.
80.
80. Well done. 80%. By age 5, what's the percentage? Not 100.
95,
A little lower.
93.
90. We'll save some time. 90. And what's important to understand about the brain, when it starts developing, think of like a plant, tree, branches. It starts developing these synapses. Now, I'm not a neuroscientist or surgeon or anything like that. I know enough just to be dangerous, as people would say. I'm just going to explain this. These synapses is what really starts developing, and it just overtakes. It's like a dandelion. No, one day you go outside, you see a dandelion. The next day, there's a million of them. Same idea with the brain. This part of the brain is the learning part. When kids get older, you notice they put everything in their mouth, they touch everything, they're doing all this stuff. We call them sponges. This is why. At elementary age, look at it. So when you're born, you have enough to do about 4 things. Who does not have children that are on this panel? You all have children? So what are those 4 things that your child did in the first few months and maybe a couple of years? Eat, pee, poop, whatever, cry. They have enough to survive. Not survive on their own, but to be able to just stay functional. By elementary age, that's when they're really engaged. That's why the kids are constantly going, why? 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 Doesn't matter what you say, it's always the why. Puberty, 13-year-olds. They have another growth spurt in their brain. Ever notice as teenagers they sleep about 9-10 hours? That's because of that growth. Kids at teenage years should actually be sleeping those hours. We should not be giving them a hard time about it. It's actually very healthy for them. But also, just as they get over puberty, after age 13 or so, they start pruning. The parts of the brain, the synapses, that are not being used are pruned. So why is this important? I'm going to get into that in a moment to help you understand, and some of you the other night heard me talk about, imagine being in a car crash. Who here has been in a car crash? Audience as well? Okay. What does it feel like? What happens to you when you go through a car crash? What happens? Peterson?
Your adrenaline just goes through the roof.
Yeah, you feel it. You're like, whoa. What else? Mr. Trainee?
Loss of control.
Loss of control. What else?
You get exhausted.
You're exhausted. All these things are happening. How does it feel? Do you feel comfortable in that state? Absolutely not. Now take a moment and put yourself in that position every day for 30 days. Every day for 30 days. Day 31, you have to get into a car. How do you react? What happens when you see the car? Stress, the heart. That reaction starts going on. It starts skyrocketing. You're feeling it. You're getting flashbacks. Now, back to brain development. Memory. Because everybody thinks that when you're young in development, when we experience trauma like this stress, adverse childhood experience, that young kids don't remember. Would we all agree with that, memory-wise? Who here has a memory that you can absolutely remember that your parents did not tell you or somebody else, that truly it's your memory at age 1 or younger? Do you have a memory? Really? Okay, one person, lucky. Most people, no. Age 2, who has a memory? Couple, maybe. Age 3, do you start remembering? Maybe. 4? Okay? Yeah. Because most of us equate, if it didn't happen, or if I can't remember it, it didn't happen. You've all heard that. Study. They took families with kids who were exposed to domestic violence. One kid had to be, age 5 to 8, the other one 4 or younger. And they did a longitudinal study. And they looked at those kids when they were teenagers. So let's take the 5 and 8-year-olds. They were exposed to domestic violence, an adverse childhood experience, which you'll learn about. What was their behavior like in school, do you think? Or in general? What was their behavior? 5 to 8-year-old. They saw violence. How do they act? No wrong answers.
Introverted.
Introverted. Wow. Most people would not say that.
Or acting out.
Most people say they're acting out, they get mad, furious. But Mr. Peterson's absolutely correct. Why? Because they actually remember. They remember. They have a memory of violence. They don't like controversy. They don't want to face it. They shy because they see the results of it. Now that
Avoid confrontation.
Absolutely. The 4-year-old or younger, what's their behaviors as teenagers? Take a guess. Ms. Greg Jackson.
I think my male colleagues are doing a wonderful job.
No, please, what do you think? Do you think they would be introverted or not?
They're doing a good job.
Okay.
Just listening.
Chuck, why
Why
don't we just
pass her for a case?
Yeah, why don't we just try to do as best you can without the questions if you can.
Okay. So what's happening is the young one will actually notice that they're actually the angry ones. They lash out. But most people would think, well, why? They don't have a memory. It's actually the impacts on the brain. Now the brain, DNA is not impacted. DNA does not get affected by trauma or the stress. It's the release of chemicals. We have the fight or flight in our system when you're born. Us, over time, when you build resiliency, think of a fire alarm in a building. Most of them, for us, we experience it, it's behind a steel case, you have to smash it, really pull down. Kids that don't have the resilience and that have that memory, that chemical memory in their system, what happens is it's the same box but it's hanging off a wire. And the slightest breeze can set it off. So this is a brain. This is an MRI. This deals with healthy versus abused. You can see the activity of all the color versus here abused, the darkness. And this is out of Romania, child. Unfortunately, both child, when they had this scan, it was after death. So let's talk about the Adverse Childhood Experiences Study and how this all relates into the brain, what's been going on, and what you've been talking about. So let's talk about the study itself, just so you know. It was done in San Diego in 1997 with the CDC. 2 primary researchers, which was Dr. Folletti and Dr. Anda. 17,000 people, 50-50 male-female. It was Kaiser Permanente, so most of them had health insurance. Most of them were middle class. Most of them had a higher education. 80% were white. Over 60 to 70% were also, lost train of thought, 50 to 60, 70% white. They had high level of insurance, so they had access. Now, most people would say that study is flawed because it's only 80% white, not looking at race. However, when you start looking at these numbers, if this population has experienced this much of trauma, it starts giving you an indication of other communities that may not have access to all these services, what they could be experiencing. So what this does, and what they learned in this study was adverse childhood experience. So you've experienced that. What they looked at was 10 key things. It doesn't capture all experiences, but it captures questions around physical, sexual, and emotional abuse, both physically and neglect. It also looked at family dysfunction. Looked at if you had a parent in corrections, So they were absent, a family member who experienced mental illness, substance abuse, and or if you were in a single family. Now, one of the things I want to really stress here is when we talk about adverse child experiences, it does not mean abuse or neglect. Just because you're in a single family, a single parent, does not mean that they abused their child. It's an adverse child experience because one parent with kids is not as easy, whether we're talking income, access to resources, and time, compared to two parents. So you've experienced an adverse child experience. You're young. The brain. We just talked about how the brain gets impacted. Then you have social, emotional, cognitive impairments, adaptation to health, risk behaviors, disease, disability and social problems, and then early death. So let's relate it to the population that we've been talking about. Again, everybody thinks it's a choice, and we talked about this the other night. You don't start out drinking 540s. Why would someone start drinking? Start looking at the impacts on the brain, the social, emotional, and cognitive impairment, how that starts affecting, as one would say, maybe choices and what's going on in their lives. So this is national study. So this is what they found out of that 17,000 people. 33% had 0 ACEs. You see 1, 2, 3, and 4. So let's just talk about population, 3 to 4. That's 26%, a quarter, of Anchorage. If you want to put it on, we'll talk about Alaska numbers here in a moment. Have 3 or more ACEs. And most likely, the population we're talking about, I would say probably over 90% of them have 3 or more ACEs. And we'll talk about why that's significant. This is Alaska. We have our current data out of BRFIS, which is the Behavioral Risk Factor Surveillance Survey. It's a survey that all states do through the CDC. Several thousand people here in Alaska participated. It's phone, both land and cell phone. And you can see how we rank and compared to other 5 states, which include states like Washington, New Mexico, Illinois, and it's a mathematical formula that the CDC came up with. So we're definitely higher. One of the other things that this study determined was if you've experienced one adverse child experience, like we just talked about, your likelihood to experience a second one is 87% greater. So if you've been exposed to domestic violence, which was one of the adverse childhood experiences that they studied, the likelihood of experiencing single parent or a parent being addicted, things of that nature, was 80%, 87%. What was amazing about this study is it was a dose-response relationship. This is the dream study of any researcher, meaning cause and effect. They were able to show. Now, one of the things I want to stress is when we start looking at some numbers, this talks about level of risk. So, i.e., just because somebody has X number of ACEs, you could do an ACE score. So that's what the study did. If you had any one of those, you got 1 point. So, you were sexually abused once, you got a point. You were sexually abused for 3 years straight, multiple times, it was 1. They couldn't quantify it. Also, if you were from a single parent, it was 1. Would we say they're equal? No, but the study wasn't able to do that. But this has led to multiple studies that have looked at that. But it created this dose response. So when we look at this, so from the study, this is smoking and lung disease. As you can see, 0 ACEs, as more ACEs you experience, higher risk of smoking. Currently smoking and COPD. 4 ACEs. So let's just say, physically abused, single parent, addicted to substance, the parent, and probably was exposed to domestic violence when boyfriends or girlfriends were coming in and out of the family. So that's 4. So let's talk about smoking. I remember as a kid trying smoking. Most people have. Hacked, couldn't figure out why anybody did it. Could be peer pressure and so forth. But the risk, look at the likelihood. It's a coping mechanism. Think about a police officer. It's a protective. Coping is to protect. They feel calmer, they feel relaxed. Think of an officer going into a house without a bulletproof vest and a gun. Would they ever do it? Take away someone's coping mechanism, you might be surprised that they act out. There's behavioral issues. Take away smoking from somebody. It's not just the addiction they experience. Imagine their behavior, what happens to become irritable. All that. It's the coping mechanism. Let's talk about alcohol. Your likelihood of becoming an alcoholic, married to an alcoholic from the study. Again, you get that dose response. Your risk level increases. So again, back to being a child, brain development. You've got that fight and flight, very loose, not protective. They can't cope with things. Hearing voices, anxiety, depression, they can't cope. Take a drink. They're able to cope. That no longer does. Take some more. You can see the growth. Suicide. Huge, especially in our state. If we don't address trauma, this is what this is about. Reducing trauma and building resiliency. Now, this is not to say that someone should not be held accountable for their actions. So just because somebody experienced trauma doesn't mean, oh, poor you, let it happen. But how we interact with somebody will greatly change if we understand where they're coming from and what's going on. If I understand this person's development was greatly impacted because of those adverse childhood experiences, how I interact with them is going to greatly change compared to somebody who I think should have the skill and ability to deal. Again, that's where that struggle comes in from choice. They're making a choice. I make a choice not to drink. That's because I have the resiliency and skill set to be able to do that. And I got that because I wasn't experiencing these adverse childhood experiences. Let's talk about economic impact. They did studies, whether we're talking absentees from work, whether we're talking illness, access of medical, health insurance, and so forth. The more ACEs you experience in life, the likelihood of the cost. Again, back to this population. Why are they so costly to us? It wasn't choice. So this study was so large that they were able to do what's called population attributable risk. So basically, what you see is what we call the oil slick. And they superimpose this. So for example, suicide, they can say that 67% of all people that have committed or attempted suicide in our country had 2 or more ACEs. Alcohol and binge drinking, 33%, which is really important. Very few studies are able to do this. They can just refer. But we can actually say that we know that a high percentage of our folks that have tobacco use, it's because of trauma.
I can't remember the original slide. How, in the original study, what was the percentage of people that had 2 or more ACEs?
Back to it. So we're talking 26, 36, 42%. Almost half. It's a lot. So the aha moment for me, think about, before I did all this work, I ran the HIV/AIDS organization. To put this in context, here in our state, 30 to 40 new cases of HIV have been identified. It's been plateaued for about 2 decades. Give or take, 1 year's 32, 1 year maybe 42. Insignificant. In the time that I worked with them, we had more money, less money. This program, that program, new staff, old staff, everything. Never changed it. Started understanding that about 60% of all people diagnosed with HIV have 2 or more ACEs. So if we address the trauma, what could happen? So we know that people with HIV, if viral load is high, because they're not taking their meds, they're more easily able to pass on the disease. But if they're on meds, which is greatly related to their connection, self-worth, so forth, which we're talking about dealing with trauma, decreases. They're more likely to also take the necessary steps to protect themselves and others. And those who may be at higher risk of engaging in high-risk behaviors, if we deal with their trauma, that goes down. In probably about 2 generations, we could see that number drop to about 15 people. And then mathematically, by the 3rd generation, maybe 4th, we could get it down to 5. Because we address the trauma and not just the symptom. Again, if all you do is focus in on the person being drinking, you're missing the point. It's like having a major gash in your arm, and if all you do is put a Band-Aid on, it's going to soak through. It's going to continue until you get in, stitch it up, and address the issue. So let's talk about that, resiliency. Resiliency is the ability to bounce back. If someone has gone through trauma, they can't bounce back, and no resiliency, they won't be able to bounce back. So imagine juggling. We all juggle things in life. If they're glass balls, we all drop them, things drop. If it comes back damaged, cracked, so forth. That's what we were just talking about. But if you can start coating those in rubber, when they bounce back, they come back whole. And that's what we want to create. That's what you all have been trying to look at with dealing with this population. Attachment and belonging is probably one of the most important pieces, that sense of connecting. If you have no sense of belonging or connecting, you won't care. So if somebody does not feel connected to their community, they're not going to invest in it. So imagine these individuals. They've already experienced abuse by people that are supposed to care for them. Bet you some of them are part of the foster care system, got lost there. Some were ripped out of their villages. Let's talk about historical trauma within the Native community and the impacts that that has had. Why would they ever feel connected or belonging or care about their community? Housing First, what does it do? Everybody says it gives them a place to drink. No, it doesn't. It gives them a home. And if I asked you all to divide a home, you wouldn't tell me you live in a 3-bedroom house that has 1,800 square feet. You'd be talking about that sense of connectedness to your community, love, caring, and so forth. When that happens, kids create resiliency. But resiliency isn't just created in kids. It can also be created in adults. Again, the brain develops. It doesn't mean after age 5, old dogs can't learn new tricks. You can still address the trauma, lessen it, give them resiliency, and they can be strong members of the community. And that's why you see in Housing First less pickups, less issues. And they're actually drinking less because they have a greater self-worth. Capabilities, creating resiliency. You establish appropriate, achievable expectations. Asking somebody who's been living on the street for 30 to 40 years to just go and live independently with no support and just quit drinking. Talk about setting them up for another trauma, failure. It's about establishing set expectations like Housing First does. They go in, they talk about, you want to stop drinking? Yes. Well, how do we start? Well, maybe 1 less beer a day. That's a huge step for them. It's achievable. They get that resiliency, then they can move forward. Community, culture, and spirituality. Another piece, that sense of belonging. If we look at rural Alaska, we have villages that have been greatly successful in lessening the traumas that they're experiencing, whether they're talking domestic violence, child abuse, whereas others are still struggling. And one of the key things that have been seen that the difference is the reclaim of culture. That they have cultural camps for the kids, that they're demonstrating dance, they're sharing their language, they're sharing the history, they're having conversations about their culture, they're creating a sense of community. That too can happen here. Same concept. Again, you see that in many of the programs that are working with this population on a small level. They create a sense of community, culture, spirituality. And when they have that, they start creating the resiliency necessary to address the trauma that they've experienced and then be able to start taking the steps to be what we would like to see as a less burden on the community. always share this just to talk about investment. If people just want to get down to money. So when you're talking about this issue, what I'm hoping I do is also plant a seed of looking at your value. This isn't about just helping the homeless who are chronic inebriates. Just that word alone is stigmatizing and negative. It's somebody who is addicted. But if we talk about investment, we want to invest at prenatal. It's the best. When we wait as a society and only do job training, we still need to do something, but we need to do it upstream. So you guys as assembly, not only should you be looking at this current population, is how do you make sure that this 200 isn't replaced by another 200? It's about making sure that we invest in early childhood. It's going to take a couple generations because it's taken us many generations to be where we are today. This problem didn't start yesterday. It's built up and will continue to build. But if we start investing at the beginning versus the end, you'll be much more successful. Questions?
Any questions for Trey?
Really, no questions?
Thank you very
Thank you
much.
for
So
your
convincing,
presentation.
there's no questions?
No,
I
it's
don't
pretty
believe that.
educational.
Thank you.
I do want to share with you guys, this gives a history of somebody, talks about his trauma. He's out of Washington, D.C.
Thank you.
And really highlights what we were just talking about.
I do want to thank you, Trevor, for that presentation. It fits in well what I think we've been doing here, trying to understand this problem from as many angles as possible. And certainly, I think the concept that the group we're talking about is, I like to describe it more of a river than a lake, and being able to take steps to really stop people from getting into this situation is equally as important as helping the ones that are currently in the situation in the long run. And so that was very helpful for that.
It's really a values. If this is truly high priority, I think there's a couple of you that talked on Tuesday, it's truly a high priority. I think it was you actually, Mr. Evans, that you collect all this tax money, it hasn't been a priority. Everybody says it is. They talk, they have meetings, but actually take action, it's not there. If it's truly a high priority, you guys are actually in a position to be able to do that.
Thank you.
Thank you for your time.
Oh, sorry, Ms. Gray Jackson has a
Thank you, Mr. Chairman. No, I want to thank you for the presentation, and actually, it's the first time that anybody that I can remember ever talked about the prenatal court and what we need to do at that level. And I think it makes a lot of sense, and it's really, really important, so I appreciate that. Thank you.
My pleasure.
Thank you, Mr. Chairman.
Okay, moving on, our next presenter, we've got a presentation from Archana from AEDC. Those of you on the Assembly will recall that we passed a resolution on Tuesday night supporting the initiative that Archana is going to talk to us about further.
Thank you, Mr. Chair and the committee members. I'll be very quick. So this Monday, we were presented with an opportunity to apply for IBM Smarter Cities Challenge Grant. And what the grant essentially means is that IBM will give us, should we win, will give us 5 to 6 of their team members, their IT department team members, to come over here, meet with all the stakeholders that we have identified for them in the application. Spend 3 weeks with us here. First week would be meeting with all the stakeholders, gathering all the data that we can provide to them. Second week would be analyzing all the data, further meetings, and third week would be they consolidate all of that, present a report to us in a presentation, but also give us a report with the recommendation and the implementation plan that again we'll be identifying in the form. So when that was presented to us, the first and foremost thing that came to our mind, because the one criteria is that this issue has to be of strategic importance to the city. And so we identified homelessness and chronic inebriate issue as the top priority for the issue at the moment, particularly coming from AEDC. We are, as you may be aware, we are aiming to make our city the #1 in America by 2025. There is no way until we fix this issue that we are going to be able to claim that that's where we are. So it was a very obvious, very easy decision. The harder part was from then on to say, okay, go make it happen. And so I've been running around asking for support, and I've been pleasantly surprised, thanks to Amanda in particular, to be able to get all of your support at this hearing. So very quickly, just an outline, we have identified that issue and we are identifying the government, our business community through AEDC and Liberty Play Partners and the nonprofit and social services sectors all together as one stakeholder group. And what we are saying is, even though this problem has been in Anchorage for decades and a number of parties and a lot of resources have been putting into this place, so why is it different? It's different because at this moment, I think all the stars are aligned when everyone is gathering together under one big umbrella to say that we want to make Anchorage #1 and we have to solve this issue. And I think with a big force coming from the business sector, it has that opportunity to look at this problem from a different perspective, from a fresh perspective, not just yet another project that means yet more money. I think we are trying to look at how can we solve this problem in a different way. And I'll take some piece from just a presentation being put together where the Band-Aid is not the solution. You have to go deeper and fix the problem from the root. So what we are looking for is, are we looking at the root cause in a proper way and not looking at this problem as yet another money draining issue? So I think we need to change that mindset. It's not about throwing money after money at this issue and hoping that it's going to fix itself. It's not. It hasn't, so it will not. So I'm building my case as I'm speaking. The deadline for report is tomorrow, and I'm gathering all the support that I can. Our mayor is on board. I got a support letter from Senator Murkowski, United Way is drafting a letter. The Ombudsman has done a letter, and a couple of other nonprofit sector. AHFC has come on board. They have done a letter. So I'm feeling very confident that our application is a strong one, but I cannot do this without the support of this committee. So I urge that I get the support and we get going. Tomorrow is the deadline. If you have any questions, please ask me now or send me an email. Quite happy to answer that.
Are there any questions at all for Archie?
No.
We have a letter of support that to be signed by the committee if they look it over and approve of it. But did you draft this?
With the help of Marcia, I just made a few tweaks.
Perfect. I've looked it over. I will certainly sign it. I think it's I think it embodies what we've been trying to do here from the beginning, is to take a really smarter look at this problem and see what outside the box solutions exist. So certainly applaud your effort.
And again, what I have made, I would say a very quick comment that even if we do not succeed in getting this particular grant, I think AEDC and Liberty Play is in this issue now. So we can't help it. We are in it and we want to work together regardless of the outcome of the application. So,
First Thursday of every month, we're here.
Yes, or more. Thank you.
Well, thanks. I apologize for cutting off the questions earlier because we do have a little more time, given how things changed around. But we do have some time for, first of all, any member comments, and then we'll get to audience participation. Mr. Honeman?
Thank you. I'm not a member of the actual committee, but I'm not sure if it's actually a committee of the whole, but I believe I actually try to get on this committee, but I certainly am interested in participating as much as I can. Now that my days off have changed, I should be available more often. Secondly, I wanted to address the fact that, and I mean no disrespect to any efforts made by any of our colleagues prior to us being on this body, or any other program that exists or has existed or is attempting to do the program, that we're trying to meet these challenges or find suggested solutions to the challenges. Just picture the fact that we're seeing this problem worsening and growing in this community, and that as a practitioner on the street level in the early 80s, late 80s, having to transport people around, picture 2 o'clock in the morning on Saturday, or Sunday for that matter, and most of the programs that we know, including the ones sitting in this room, most of them are 8 to 5 Monday through Friday. And so what generally defaults is to our general government services, our police, our fire, our transit or safety center, which used to be called sleep off or CSP or however you want to do it. It had been a small portable that was behind the old original Brother Francis shelter with just flat mattresses on the bed. And I believe there were, I don't remember the number, but I want to say it was around a dozen. Well, in the original version, there was about a dozen mattresses laying on the floor. And once you got full, you had no other place to go. Really, no other place to go. If you had someone who was duly diagnosed with a depressed and they were threatening to hurt themselves, we tried to take them to a state-run facility under Title 47, which, by the way, isn't an option. We have an obligation to our community at the, I hate to say it, at the mandate of the state, but it's under Title 47, and we don't have a choice. We have to do something. It's been left to our general government services, and that's where largely our funding has started and stopped. And I'm not to say that we haven't had great programs that we've facilitated or mediated or helped apply for or stood in support of. We've done that. We've always, like the Seattle Seahawks at Super Bowl, we get to the 1 yard line and we give up the ball and we go back. And I'm sorry, it's frustrating, and I will just say to my colleagues that, as long as I've been in this community, and I'll continue to be in this community, I'm going to be relentless, I'm going to be firm, I'll be patient, but I'm getting to the point where it's going to be continual pressure, and I'm challenging everybody in this room and outside of this room. We need to come up with some solutions. I asked questions earlier in the presentation, what's your funding source, what's your funding source? Have you identified funding source? Housing First seems to be a good model, I will not deny that, but if we don't have the funding, we got a big problem. And I've heard several grants that are going to expire. I understand 16 and 17. So where are we going to come up with the funding to continue the relentless pressure that we need to deal with the issue? Thank you.
Thank you, Mr. Norman. Thank you for being here today. Ms. Dombrowski?
I'll just respond by saying that's the exact point of this committee. And we said the first 5 meetings that we are going to default to action, but you can't default to action without first holistically looking at the entire scope of the situation and what services are provided. So you have to understand that before you jump into, just grabbing $10 million. I mean, you have to understand what is available so we can streamline it and make sure that we're effective and deliberative in our process. So though I know you're dismayed that the alcohol tax didn't get on the ballot, but this committee has been committed. I think every single one of us is committed towards action, but we don't have a plan yet. And that's where it's at. I mean, we are all committed. We don't sit here for 2 hours every single time because we don't want anything to happen. This is the first time in the history of this city that the assembly itself is taking the lead on this. And I think because of that, we're the legislative body and we're the appropriating body, I think you will see action. So this is different than every other task force. So I appreciate your passion because I think it's shared among many of the committee members. It's just how do we get there?
Mr. Peterson?
Thank you, Mr. Chairman. Part of what we're going to have to do to be successful in reaching our goals is we're going to have to sell the community on what our plan of action is. And one of the statistics that I caught today, and I made a note of it as soon as I heard it, one of the presenters, I believe it was in the Choices presentation, said that for every $3 spent, they save $10 in additional governmental services further down the road. And so that shows that some of these programs are a good investment of public dollars. And so those type of statistics are we're going to have to provide to the public to get them on board so that we can make this happen. Because just us wanting to do it is not going to make it happen. It has to be a community thing. If everyone in the community gets on board, we can be successful. Thank you.
Thank you, Mr. Peterson. Any other comments?
Yeah.
You look, go ahead. Go ahead.
First off, thank you for letting me sit in today. When I first came on the assembly with Ms. Dabowski, we toured some of the facilities, including the sleep-off center, and from that came, we saw an additional need, and from that came the new van, new personnel to help at least fill the sleep-off center. But it's got to be dealt with, and it seems as though you guys are going in the right direction, and that we've got a lot of different folks, community folks, service organizations coming to the fore and saying, hey, we can help. And so I think we will get it done. The only thing I would say is we have the money. We're spending the money now on police, extra fire, extra incarceration, sleep-off center, And I know there's resistance out in the community. They have fear of folks that are not like them or folks that have problems. And so I like the idea of spreading it around, which is a lot of the service organizations are doing that. And I think we will find a solution to it. And I really appreciate that.
Just quickly, and I wish Mr. Boss were here because, again, I mean no disrespect.
Hits and runs.
I understand, and particularly on this committee, at least 2 of the 3 of you on the committee in this room at the moment, in the last couple of years, adding on to the body itself. But one of the things that struck me very like a 2x4 in my face meeting tonight is that not only were we hearing, and we will hear from the public, that they don't trust their government or their elected officials or their politicians to do what they say they're going to do with the funding. That you're asking for this level of funding for here, and then at the last minute it's diverted or transferred over to something else. And with good reason. What I will challenge you is, and again, I say I will be patient and I will be a participant at this meeting and going forward, looking at all the options, because there are many new ones that are coming to our community. But we have studies, and we have plans, and we have had blue ribbon commissions, and we have had task forces. It's for the lack of perhaps you not knowing about them, or maybe you haven't seen them or haven't studied those before, have not been presented those. But many of us in this community, many of us in this community, and you've all certainly been here, there are lots of programs and plans, and a lot of great programs and institutions that want to do something, and again, they fall short in the funding level. And so, Mr. Seal, you said we've got the money. Yes, we do. But every penny of the money that we have obligated under our general budget is going to services that we are remiss in providing in some degree to our community. We cannot, I do not see where we have room in the budget under the general operating funds to pay for new programs without new funding sources. Now, maybe it's going to the state and asking for the alcohol tax money. Perhaps it looks like we may end up having at the local level to be brave enough, courageous, to find a new funding source without basically robbing Peter to pay Paul. We are not going to be able to reduce the size of our police force. I dare say we need to increase it. And it's an expensive source. For other issues, not just this.
It'd be on the street writing tickets rather than servicing.
I'm going to yield because we only have 2 minutes left, and there's some folks who want to talk, so I'm done.
Yeah, well, I'm not going to be as generous. I'm going to make a quick comment on that. And I'll be pretty blunt about this. I mean, we have looked, I mean, at least I've looked, and the other assembly members have had access to all the other studies. That's how we started this process, with seeing what's been done. So we are aware of it. I think one of the problems, and I think one of the things I want to see differently this time so something gets done, is you have to take into account sort of the political factor. I mean, a lot of those studies talk about things that, there's basically different kinds of folks that want to address this issue. There's the people involved in these industries that help. They're out there on the front line dealing with these people, trying to get them help, and the people supporting them. And also we've got the cold-hearted bastard conservatives that don't want to spend money on the issue, and and I kind of represent that viewpoint for the most part. Realizing, I mean, that's my position here. Is I take sort of the smaller government. This is not our problem kind of issue. But I do want to solve this problem, and I think that any solution that has a chance of actually getting community buy-in in our community, because we have that same divide in our entire community, is going to have elements that appeal to both of those factions. There's going to have to be elements that make the people that talk about personal responsibility say, oh yeah, that's, I like that. But at the same time, it's going to have elements that, on the other side, it's going to provide those treatment centers and have that cost associated with it. When I looked at all the other plans, it didn't have that necessarily. It was just, spending money on things that are actually needed, but without the political support on both ends to get things done. And that's what I'm hoping, or we're hoping to do, I think, on this committee. And, if we can, that'd be great. But that's at least where I'm coming from. And so people know, I don't ever try to hide that fact. That's where I'm And now that Ms. Gray Jackson has yielded her time, I know there's a lot of public comments, so, and I appreciate the great turnout again we've had.
Mr. Chair, Mr. Steele, there was a question you asked about why 2 programs and are they coordinating? And there was a very specific answer that they didn't mention, and that is in the terms of the RFP, under one of the 2, the ACT team proposal, it was specifically restricted that all of the services must be provided by the grantee. And then the case management side, they had to broker services. And so the one side was actually restricted from being able to have a specific partnership. And so it was actually the wisdom of Juno that did that. And so I give credit to the grantees that they are going to work around it, as they said. But the nature of that was that they were specifically excluded for some very unknown and must be smart reason.
Great grant has strings.
Right, and so that's where that came from. And I would like to point out one last item, I won't talk long, but that we've heard lots and lots and lots, and we've seen massive funding to Housing First. And no one's going to deny in this group that that's the zeitgeist. This is what we've been funding in Anchorage, actually, since 2009. There hasn't been an additional increase in treatment services since 2009. But we've seen millions of dollars now being moved into Housing First. And so anytime you hear a big group of cheerleaders stand up say, we need to fund Housing First, don't forget that there are the other services that actually need to grow at the same time. And so it's a disservice to the broader efforts to help these people to say this is all we've got to do. And that's unfair to the individuals. It leads some people to conclude that the vision of the people providing or directing these services, Housing First, they really just want them to go and die because they don't want to see the services funded. I won't say that because I believe in the goodwill of the providers. I've worked with the providers for years now, but we need parable growth. We need to help people move out of that as well. In the model they showed you, they aren't going to provide substance use services. They're going to provide assessment services and coordination, right? That's what it said on their PowerPoint, which means we're going to, if there's funding somewhere, move them to a place where they might get help if that's what they want. And so just keep the big picture in mind that we have to look at both sides. It's an important thing. Thank you.
Ms. Gray Jackson
Thank you,
has
Mr. Chairman. I just want to make one comment, okay? And I really appreciate your comment that Housing First is the only thing to deal with. But I don't think there's anybody on this committee that said, okay, Housing First, that's it, we're done.
I agree.
We haven't done that.
I know.
So, you know, we are very open-minded. That's why we have so many different agencies come and talk to us. So that's not where the ball stops in Housing First.
And I respect the work
Thank you,
you're
Mr.
doing.
Chairman.
You're welcome. And I just want to say, I know that, this money didn't go the way exactly Fairview wanted it to go, and there's, angst about that. But I do want to thank you for doing the work that got this money back to Anchorage anyway. For that, hopefully this will do good, and you guys are responsible for that, even though it didn't come out exactly how you wanted it. We do appreciate the effort in lobbying for this.
And one last note, we're going to lead the charge to bring 50% of those taxes back to this town. We're not waiting for anyone to get in order. We're going to lead the charge. And we want you to be with us, so that's it.
We'll help you. Ma'am, you had a comment?
Yes. So I have a couple of things. First off, leftover from the meeting, there was kind of a numbers put out there for how many beds are available for detox. And I would like to mention that you guys may want to do a little more research on that or get somebody else to research it, because some of those beds may not really be available to everybody. And because there's
set-asides for natives, I believe.
yes, that's part of it. And even though publicly, you can read on the website and all of that, that's said, I'm not sure if the partnership that Ernie Turner has with the city actually involves the city giving them any money. So if that's not the case, then they have to go where the money is, so that would be to the native corporations. So, I'm not like criticizing them, I'm just saying, Aquila House, Ernie Turner, they got to go where they know they're going to get the money if they're not getting the money from anyone else. Aquila House, I know that they have, people who are court-ordered, and, they have to go where the money is, and these people need the services anyway. So, those people are going to get the beds first. That's just a business reality. Secondly, I would like to challenge, one of the things that I heard mostly from the crowd at that, but from some folks here a little more subtle, is speaking about the inebriates and recovering alcoholics, those people, those folks. Some people in the audience even saying they should be put on a chain gang, that kind of thing. I would like to give you some homework, and I would like you to, in the next month, go to just one recovery meeting as a visitor and sit in the back and listen to the people sharing about what it takes for them to get sober or clean. That's the challenge I want to get. It's easy to find it online. There's schedules online. If you want to, Sunday at 11 a.m., I'm celebrating my birthday, so you can come over to Viking Hall and come there. And that's probably beyond what I should have said. Put faces, because frequently there's people in there who have come off the streets, and that's part of it. Third thing, not every recovery has to involve treatment. Community is the most important thing. I never went to treatment. Okay, my ACE score is 7. Okay, it's 7. I never went to treatment, and but I was very fortunate. I also didn't come from poverty. I searched out things. I couldn't work after I gave up alcohol. That's how you know that you have mental issues. I had to quit my job after giving up alcohol and drugs because I could not cope with life. And it took me 3 years of therapy and recovery and all of that to be able to do it. I searched out my own training programs. I searched out my own therapy. I searched out all of those things. There's people out there that can't do that. They can't do it. Okay, and now my resiliency score is actually high. And the reality is that there's a lot of people that have gotten, the most important thing for me was finding a community of people that cared about me. That's what I found. And a lot of what they were talking about up here is there's a way to have sober housing where, the having meetings there or whatever, it doesn't always necessarily, once they're detoxed, have to involve long-term treatment. And some of that, is very helpful. So there's that piece of it. And anyway, the challenge I'm giving you that challenge.
Thanks for coming, thanks for the challenge.
Yeah.
I just wanted to real quickly say, I made the commitment at the meeting the other night, and it's there. If you would like to take the time at your community councils to have us come speak, we are going to Juneau. We would like your support. We're willing to come talk, just like we did for the last effort we made. And I really invite you to use us, because if we can have your support, we can accomplish.
Rosalie and then Sylvia, about 15 seconds each.
Just, I wasn't going to say anything, but a response. Court order doesn't mean money comes with it. What happens is that the court may say, you've got to get treatment, Johnny Jones, and Johnny then has to try to find some money to get treatment. And that isn't from the treatment centers. We end up with a limited source of money. We may have empty beds, but we don't have funding to support those beds. And that's every treatment center.
Last comment?
I just want to say that the Alaska Hospitality Retailers, which is our association, we have a lobbyist now in Juneau that's starting to work for us, and we are partnering with the Fairview Business Association, and I said it right, and we are going to go for those tax dollars. That's our commitment.
Really quick, Mr. Jackson.
And also, Dick and I are going to be in Juneau next Wednesday and Thursday, and we're definitely going to be asking for some of that money. And I just sent an email to Paul Fewes and let him know that, so, yeah. Thank you, Mr. Chairman.
Thank you.
Amanda has a sign-up list. If you're not getting the emails and would like to, she'll get you on our list. Also, just a reminder that next Friday, the 13th, we are having a meeting. What time is it, Amanda?
11 to 12, and I haven't sent out the email yet, but it'll go out this afternoon.
Yeah, this one does. These are the out-of-state people that we just having to take advantage of them. It'll be recorded, Paul, though. But and again, it's a housing first focus, I believe, is their main focus for this folks in Minnesota. So hope to see y'all. It's what's
11 to noon.
11 to noon, just an hour. Thank you.